Can everybody hear me? Oh, you can hear me. Thank you for putting up with us. We're trying to do a live demo on stage, so we just basically installed capital equipment of a medical device system on stage. It doesn't look as pretty because we don't have the full suite because we're not in a hospital setting, but hopefully it gives you a good idea in a little bit. But before we get into the live demo, we want to give you a little bit of an understanding of who MediView is, what we do, and what you're going to see in the live demo. So MediView is an augmented reality surgical navigation company. So we're trying to bring additional information to the clinician during different complex procedures so they have X-ray vision or superhuman vision. So right now, if you think about a cancerous tumor patient, the most successful treatment they can get is an ablation of their cancerous tumor on the liver or the kidney, and ultrasound is used to guide that procedure. No clinician is trained classically during their training on ultrasound, so a lot of them aren't comfortable using ultrasound during these procedures. Therefore, most patients don't get the most successful treatment for their cancer. About 25% of cancer patients that have tumors on their liver, their kidney, will get a minimally invasive approach, which is obviously less painful than a clinician coming and opening you up and doing the same thing. So what we're trying to do is give them more visualization tools so they feel more confident during a procedure and the patient can get the best treatment for their cancer. Right now, if you don't get an ablation, you get chemotherapy, which a lot of people understand the side effects of that. You get radiation and or you don't treat it at all. So why is there poor visualization? You can see on the screen, ultrasound is the standard of care imaging used during these procedures. It's a very thin slice that the clinician's looking at when they're scanning to look for a tumor. So sometimes it's very hard just to locate the tumor itself, yet alone find it, target it, and ablate it. They take pre-op CT scans a couple days, a couple weeks before a procedure. As soft tissue moves, because you eat, you breathe, you go to the bathroom, so that pre-op CT scan isn't necessarily accurate to the day of the procedure. So the clinician during a procedure is looking at that pre-op scan on a boom screen in the operating room and then using that live ultrasound image, and they're trying to create a 3D anatomy in their head of the patient to understand where is this tumor, what is the needle trajectory I should take. So a lot of cognitive load is being put on the clinician during these procedures. What we're doing is taking that cognitive load and reducing it for them. We're taking that anatomy from the pre-op CT scan, taking it through what we call a segmentation process to create 3D anatomy, and then we load it on our headset that you can see over here, and we give the clinician X-ray vision. So MediView as a whole, we're really, our purpose for why we exist is to create a peace of mind through confident and simplified clinical decision making. Really want to take the guesswork out of everything I just described. A lot of it is subjective, based off the case, based off the clinician, based off their experience. So how do we do that? You can see that first thing under Simplify. We're really trying to give them additional visualization tools. So during a case, they have a better understanding of what they're looking at. We also want to democratize it through collaboration. So you'll be able to see in a little bit, we'll do a live demo, and everything you'll see on the screen during the live demo is something that another clinician, maybe at the Mayo Clinic, at Johns Hopkins, or Cleveland Clinic can see. And if you are the clinician in, say, rural Kansas, and you may not be as experienced in a complex case, but you want that on-call feeling from a world-renowned clinician, you can have them guide you through a procedure. And also informing, this is an AI Expo, so in the background we're collecting a lot of data to create data insights because we want to be able to tell the clinician what needle trajectory to take, what amount of ablation to apply. So what we do, as I kind of explained, is we're really taking that anatomy and we'll place it on the patient in real time. It's about 2.5 millimeters accurate to the physical world, and then we incorporate that live ultrasound imaging. And that live ultrasound, you can actually adjust the anatomy to bring it into actual physical space of where that patient's anatomy is at that moment in time, where previously you're looking at that CT scan that may not be accurate to the present day. And I won't show you the video because we're actually going to do it live for you. So a few things you'll see in just a few minutes. We have a heads-up display. We've done studies with Ohio State University and Memorial Sloan Kettering in New York City to show the ergonomic benefits of just bringing the ultrasound into line of sight of the clinician. In a typical procedure, it's usually across the table. It's to the left, it's to the right, so you're constantly turning away from the patient. So just by having it in line of sight brings a lot of ergonomic benefits to the clinician. We also guide your instrument, so we'll track the needle trajectory so you can see if you're going to avoid critical structures and make sure you're going to hit that target successfully. We take 3D fusion of the CT and ultrasound to create those 3D anatomies, so it gives you that X-ray vision. You have the ability to use hand-free controls to control the ultrasound. So if you want to increase depth, increase gain, you want to show different levels and layers of the anatomy, you can turn it on and off. And a lot of these cases are done in a sterile field, so you don't want to be touching different monitors if you don't have to. And as I already discussed, you have the ability to first-person remote collaboration to really get additional insights from world-renowned clinicians as needed to help guide a surgery. And just something that we see a lot of use cases for, we're in a lot of different conversations with a lot of different military branches, is there's a lot of opportunity. There are handheld ultrasounds out there that are about the size of this clicker. And if you have this handheld ultrasound in a headset, you don't need all this equipment you see us trying to put on stage right now. So you can actually do more diagnosis in the field when evacuation may not be something that can happen within that golden hour of that first 60 minutes of a trauma. So as you can see on the screen, a medic can have a headset on, they can have just a small handheld ultrasound and really start doing some of the treatment to the patient. And as we incorporate AI into our models, we really want to enable decision-making and assistance. So if a medic, you may not be doing complex procedures on a regular basis, but if you do need to do one, you can ask our AI model to kind of guide you through it, make sure you've done it successful. And if you really want to go in and collaborate with somebody, you can do the same thing, remote in, and have somebody else see everything you're seeing to really help you guide the procedure. So our goal, and we'll get to the demo in just a second, is really take that continuum from open surgery and change it over to minimally invasive. So right now, 75% open, 25% minimally invasive. We want to flip that, which also means that more cancer patients are going to get the care they need. Open surgery isn't something that a lot of cancer patients can get because it's extremely invasive and their comorbidities due to the cancer don't allow them to get that treatment. We want to move it away from the expensive CT suites. They cost a lot of money. They're always booked up in the hospitals, and allow it to happen in interventional suites or even in ambulatory centers and outpatient offices. There's a lot of expensive resource cost associated with being in those CT suites, so moving it out of those suites saves the hospital and the patient money in the long run. And interventional radiologists are typically the only specialty that does these procedures. There's not a lot of interventional radiologists out there, so if we can give the ability for other specialties to perform some of these procedures, again, giving more access to patients for the best care they can have to ablate and kill that cancerous tissue. And with that, if Addis wants to come on stage, just as he's coming on stage, we do a lot of partnership with the Mayo Clinic, with Cleveland Clinic. We're doing a lot of multi-center clinical studies with Cornell, with MedStar healthcare system here in DC, with NIH. We've partnered with Siemens, GE, Microsoft, et cetera. So we want to be able to do that, what we're doing, without their help. So we appreciate that from them. And with that, we're going to see how this goes. Addis has never had a headset on, so he's going to do a live demo for the first time of our technology, and Crew's going to kind of walk him through it, and then if we have time, we can open up for some questions. Yes.
All right, so we're going to walk through a demo here. I'll have you put on the headset. It's going to ask if you want to adjust for your eyes or cancel. I need you to reach out and press that cancel button when you see it. And we're going to pull up what he's seeing through this headset so everyone can watch on the screens. So you got to kind of press all the way through. Pretend it's actually there. Did it go away? Okay, perfect. All right, so now I'll have you step in front of the Phantom and look up. What you should see is a virtual display of the ultrasound. And this is really helpful because OR rooms are really crowded. So there's a bunch of screens everywhere, equipment. So using AR, you can place that screen anywhere in your field of view in an ergonomically comfortable location. Now, I'll have you gaze down into the body, like tilt your neck down. And what you should see is a virtual ultrasound projected into the body. Is that showing up? Yep. Perfect. So what we have going on here, we have an electromagnetic field generator underneath the patient. They lay on top of the table, and then we track all the tools within the field. So we can, as you'll see as I move around the ultrasound, it's going to follow me with 6 degree of freedom tracking. All right, so feel free if you want to maneuver that, get used to it a little bit. And this is really helpful to learn ultrasound because you just look at this flat panel screen here. It's hard to understand what you're looking at. But now if you can correlate what you're seeing with where you're scanning on the body, there's a lot of help to learn the ins and outs of scanning patients. And also with the EM field, we have a track needle. So do you see a dashed line coming off the needle? Perfect. So this dashed line is going to give you real-time feedback on the alignment of your virtual trajectory with your ultrasound. So if you want to grab the needle with your other hand now and try to line it up kind of in plane, and you should see it actually will change color to green. You see that little cone on the end? Yep. So that represents your needle tip. So this is going to help the clinician line up their needle trajectory before they have to puncture through the skin, so they can make sure they don't have to retract the needle out of the body and then do a re-entry. So lastly, we take a preoperative CT scan and we segment out all those different slices and create 3D models, and we can overlay that over top of the patient. So we're gonna try some voice commands now. I'll have you say, show tumors.
Show tumors.
And you should see some purple dots show up in the body.
Yes.
Okay, so now say, show liver.
Show liver.
Now you should see the liver pop up in yellow there. And now say, show all anatomy.
Show all anatomy.
Perfect. And now you should see all the bones. You have the kidneys, the veins. And this is really helpful because sometimes tumors are hard to locate under ultrasound alone. Sometimes they don't show up very well. So by co-locating it with the 3D CT anatomy, it can help clinicians plan out their insertions to make sure they're avoiding any of those critical structures, like if your tumor is on the lung or if it's near the portal vein, making sure that they're not puncturing something they don't want to puncture. Yeah, do you have any questions?
I don't, but this is incredibly cool as a first-person viewer and a user.
Absolutely. And I'll hand it over to Adam now to talk through some of the AI.
Yeah, so no Addis can go come for surgery, right? You can stay up here if you want, or you can be done, whatever you want.
Should I take the headset off?
If you want, do you want to keep it on?
I'll get off.
And so what you were seeing, like even seeing that needle trajectory, I talked about it a few minutes ago, is you have, thank you, Addis.
Thank you.
You have the ability to track the needle, but we're collecting those insights in the background so that if an experienced clinician is trying to reach a conspicuous tumor in the upper dome of the liver, for example, it's really difficult to see under ultrasound. It's really difficult to see under CT. But with our anatomy, you have the ability to visualize where it's at, and you're able to use that needle trajectory to plan it. So we want to be able to collect that insight, so if a clinician is having issues trying to figure out where they should do their needle trajectory, we can give them suggestions through our AI model. There's also something called ablation zones. So when you do an ablation, you have to understand how much heat to apply, how long to apply it, and how much pressure to put on that cancerous tissue, because the goal of that ablation is to kill all the cancerous tissue. And if you don't know those three parameters, you kind of guess it and do that mental math in your head while trying to create those 3D anatomy of the patient in your head. So again, removing a lot of the mental and cognitive load off the clinician and helping them understand just based off the anatomy they're seeing, our tool can say, here's the ablation zone you should apply. In addition, you kind of saw in the military slide with the medic is if you're in the field, we want to be able to have a conversation with our AI model. So if you need to understand how to do an ablation, I won't go into other use cases, but like an ablation, you can ask the tool, how do I perform an ablation? And it will kind of walk you through the procedure so that you can actually take care of a patient that you may not have understood how to walk through it. You may not have access to do a remote collaboration with another clinician. So really giving more access again to the treatment that the patient needs as fast as possible. And with that, I can kind of close up and open it up for questions. I think we have like 5 minutes. So if there's any questions, welcome to take them. And we do have a booth over by the Marines too. So if you'd like to be Addis and put a headset on, you'll have the opportunity. once we get set back up.
I actually have a question, Adam. So what's the most ergonomic version of this that you would deploy in the field? Like, what are you working towards? You know, you have this setup, which could be cumbersome in a battlefield setting. What's the goal? So it's
A
just
headset,
that.
and there are wireless probes, so just the size of the probe, no wire. So there's the ability to do that, but we're working through ARPA H grants with Verizon, some of the communication companies, because you need to have connectivity. So working through the connectivity is a big part, but that is our end goal, is headset probe. You have a question?
Yeah, thanks for your presentation. One of the things I've heard in the conference the last couple days is there's AI drift. When you couple that with when you're using medical equipment, you also have to retest, run it, make sure it's hitting your standard mark every time. How do you handle that both in an OR and in the field? Because those seem like two challenges where your equipment could go off and you're taking off the wrong tissue. How do you guys address that?
Great question. So we're not actually going to automate any treatment for them. We still leave it in the hands of the clinician to make the final decision. We're giving them additional information. So taking historical case data and saying, based off all the cases, this is what our tools suggest you should do. And because we're healthcare and regulated by the FDA is not there yet either, fully automated AI, so working through that. They did release ELSA, if you're familiar, an AI tool they're going to use to review submissions starting this month, so we'll see how that goes. But that's kind of our goal, is to slowly add the features and automate more and more as AI becomes more streamlined, becomes more precise. And then we go through those regulatory processes as well, which means lots of verification, lots of validation, lots of human clinical studies to validate the tool.
Thank you so much. This was very exciting to watch. What are the risks for the patients with this technology?
We don't necessarily have any direct risk to the patient. Most of our stuff is from a clinical perspective. We're not the ablation therapy, we're not the ultrasound company, we're not the CT scanner, we're a software company that are doing additional visualization. So the risk to the patient would be that the clinician uses our tool, similar to the question over here, to make the decision. So when Addis was doing his procedure, you might have seen something pop up that said refer back to the GE display. We're not standard of care imaging. You shouldn't be making diagnoses off our tool. You need to refer back to the ultrasound. So our risk gets offset because we're not the diagnostic tool.
Hello. I was just wondering, you're working with MedStar and a couple other neighboring hospitals. What have you done so far to implement the technology in the hospital? Or is it kind of just talk and like working through it, or are you implementing it right now?
We're currently commercially in the MedStar healthcare system. We're in a few other healthcare systems, Cleveland Clinic, Mayo, we're out on the West Coast as well. We're up in New York City, so doing commercial cases with interventional radiologists. We've done multiple, I think 10 or 15 cases in the last couple of weeks here in DC with MedStar at Georgetown and at MedStar Central. And also doing a lot of different clinical research trials too with NIH, with some other clinical partners.
So, what do you think would be the estimated cost decrease using this technology, if you have like an estimate, maybe?
Great question. We're actually kicking off today in New York a multi-center clinical trial to really understand what the cost reductions would be. From a private payer side, they really want to understand procedure time. So there's a reduction in procedure time. One of the hardest things is to find the tumor under ultrasound. It takes 10, 15, 20 minutes. If we do it immediately, like you can see these tumors on the screen right now, reduces procedure time, reduces anesthesia. It also, as the crew was saying, reduces amount of resticks. And in normal, without our technology to confirm placement of needle, you run the person under a CT again to confirm needle placement, so reducing the number of CT spins, so a lot of cost reduction just in that. So in about 18 months, we'll have real data to support the reduction in procedure time. All right, and I think we're good. So I appreciate it. Thank you. And if you guys do have more questions, we have a booth over there that you can come try it out and let us know.